So welcome everybody to the second of our spotlight sessions focused on consultant clinical scientists in NHS Wales. This is a particular focus session around clinical physiologies. And the reason for this is that when we initially put the guidance document out around consultant clinical scientists in NHS Wales, it was realised that the professions in clinical physiologies were perhaps the ones where we had the least number of clinical scientists in consultant roles currently, but a lot of interest in developing new roles, exploring what that means, both from the profession itself and also from workforce directors, from finance directors in the health boards in NHS Wales. So we've convened this session starting off with a few speakers who are consultant clinical scientists themselves in clinical physiologies. Our first speaker, Jane Wild, is in NHS Wales, and other colleagues join us from NHS England. So really appreciate those individuals for helping us out today. And then we'll have about half an hour then for question and answer. And please pose your questions into the chat and we'll pick those up and pose them to either the speakers or to others in the room who may be able to answer. So I hope this session is going to be useful for you. We're also recording it to put out on YouTube, and that'll be available with Welsh subtitles shortly afterwards. So I'd like to start off by welcoming Jane Wild, who's consultant clinical scientist and head of adult audiology in North Wales, who's just going to speak a little bit about the consultant clinical scientist role in audiology and her own role particularly, and give us a nice opener for the brilliance of these roles in NHS Wales. Thank you, Jane. I'll pass over to you.
Okay, so thanks, Sarah, and good afternoon, everybody. So consultant clinical scientists in audiology in Wales, they're not new. In fact, they've been around for more than 30 years. And just as a little bit of background, I started working in audiology in 1994, and I've been in my consultant post for the last 7.5 years. So I've been asked to give a brief overview of my specific role as a consultant clinical scientist in audiology, and that's quite tricky in 10 minutes, but I'll give it my best shot. It is important to note that this isn't a blueprint. So this isn't a blueprint for consultant clinical scientists in audiology, and all the roles will vary. And I'm going to approach this by giving some examples of what I do within my role, structured around the 5 good scientific practice domains, referring where I can to some of the subdomains. And just as a little disclaimer at the start, although I might include an example in a particular domain, it's probably not limited to that domain and will likely span many of the others. So before I share some specific examples, I just want to start with a brief mention of my overarching role and responsibilities as the head of service and professional and managerial lead of a range of adult audiology services. So this includes a first point of contact, advanced practice audiology service in primary care, a tertiary care auditory implant service, and adult hearing, tinnitus and balance services. So as you'd imagine, that role involves a wide range of activities and responsibilities related to finance, workforce performance, quality and governance. But I'm going to approach this, as I say, by sharing some specific examples within my role as a consultant clinical scientist linked to the GSP domains. So starting with professional practice domain and specifically patient-centred care. So in addition to it being part of my own professional and clinical practice, I see my role very much as creating the culture and systems that support the rest of the team to deliver and develop patient-centred care. So this would include, for example, ensuring that service improvement and development and research plans are focused on this. And one good example of activity related to patient-centred care for me would be the design, implementation and development of individual management plans. So that's across adult audiology. And that work has involved much collaboration and has spanned a number of years, and it's still ongoing. So this has started with the design and implementation of IMPs locally. It progressed to the development of a new patient-reported outcome measure linked to IMPs, and which involved clinical research by some of our STPs, and more recently applying for and getting capital funding to design and commission a module for audit base, that's our audiology patient management system, to record and extract this PROM data. And that module now is core feature of audit base and available to all users across the UK. So scope of practice is an interesting example, and as well as ensuring good governance systems are in place again, and that people, including myself, operate within our own scope of practice, I also see my role as very much about exploring and extending that scope of practice. So thinking about what roles audiologists can do that perhaps provide solutions to challenges that exist elsewhere in the system. So of course, this isn't just about taking on more work, but needs to include making a successful case to ensure that resources follow the patient. And a couple of examples of this are illustrated within this diagram here. So up until the 1990s at the top there, by the time a patient saw an audiologist, they had already seen both a GP and an ENT doctor. And this all changed in the 1990s when direct referral for hearing pathways from GPs to audiology were established. But more recently, we've extended this direct referral to include tinnitus and balance pathways, and have been able to improve it even further by enabling non-medical referral for audiologists for MRIs. So this change in scope of practice has reduced the need for many more patients to be seen by ENT colleagues. And another example, sort of further down the bottom of that diagram there, moving audiology even further up the pathway, we have recently begun the full rollout of what we understand to be the UK's first advanced practice audiology and primary care service. And this is where advanced practice audiologists have become the first point of contact for people with hearing, tinnitus and balance difficulties in primary care settings, which has released GP capacity along with a wide range of other benefits. And just to quickly touch on a few other roles related to professional practice domain, I'm able to contribute to the learning of others on an ongoing basis through clinical training within my own clinical practice, but also through supervision of STP research projects and as a HSST supervisor more lately. I like to think I'm an ambassador for healthcare science in all, or at least most of what I do, but this is perhaps exemplified more clearly in my current role as the healthcare science representative on the Health Board's Health Professions Forum, and that's a role that exists in all health boards in Wales. Perhaps not unexpectedly, a large part of my role is working with others, often at a strategic level and often in national forums and with other organisations or professionals. I see this as a key and essential part of my role in raising the profile of audiology, having influence on the direction of travel, or ensuring we have the opportunity to have a seat at the table, whatever table that might be. Moving on to clinical and scientific practice, my role continues to include direct clinical practice, and I have regular clinical sessions. This requires activity across most aspects of both clinical and scientific practice domains. My area of clinical practice specialism is the assessment and management of adults with complex learning disabilities or living with later stage dementia, like I say, which involves advanced clinical and scientific practice. And I also have a specific role of clinical team lead in this area. However, as similar to previous statements, as well as my own clinical practice, much of my role is ensuring effective systems and processes are in place to enable and ensure good clinical and scientific practice across all the range of adult audiology services that I'm responsible for. I just want to pick out one other specific example of my role within these domains related to quality assurance. So I've had the great opportunity to get involved with QS and QA activities nationally. I was a member of a Scottish-Welsh collaboration and a working group that developed national quality standards. I've also held the role of a national coordinator, overseeing and evaluating the external audit of adult hearing services across Wales. And I've been the clinical expert on a NICE guidance and a NICE quality standard development committee. And taking on all of these roles has enabled me to contribute to, and to some degree influence, the development of national policy and guidance related to quality and quality assurance in audiology. So I think for some healthcare scientists, including consultant clinical scientists, research can feel like the most daunting part of GSP and perhaps the most challenging to fulfil. And I think for most of us, research activity is predominantly not about being the principal or chief investigator of a study, although that will feature from time to time for many of us. And it's really important to recognise that our research covers a wide range of activities. So whilst I might be a CI or a PI from time to time, I spend more time doing other things like being a co-applicant on other people's research, being a reviewer for peer-reviewed journal, being a member of a study steering groups, supervising STP and HSST research projects, as well as taking the lead on things like developing the local research priorities, or at times contributing to development of national research priorities, and of course supporting others in the team as well to participate and engage with research as much as possible. So service development and innovation is a substantial part of my role, and as you might expect, it's ongoing with multiple projects underway at the same time, and I just included a few examples here. For some projects I might be the project lead, but more often my role is working with the wider team to identify and prioritise what we do and then supporting others within the team to take those developments forward. Overall, I see my role, one of the biggest parts of my role within this domain particularly, is developing and maintaining a culture where there's an appetite for R&D and where people are enabled to participate as part of their day job, and ensuring R&D isn't seen as an add-on or something that others do. And finally, onto the last domain of clinical leadership. I said at the start that there would be much overlap within these domains, and leadership certainly features across all of them. My leadership role covers all the services I'm responsible for and includes, I think, quite prominently, the implementation of a team-based working philosophy and structure. So this enables others in the team to develop their leadership skills and lead specific clinical areas or projects, which is both important and really valuable. I've also had the opportunity to extend my leadership role outside of audiology at BCU, and by taking on other leadership roles. So this includes the chair of the Audiology Wales Heads of Service Group, a trustee and officer of a National Learned Society for Audiology, the British Society of Audiology, chair of a National Clinical Special Interest Group, and the chair of the Health Board's Health Professions Forum. So whilst these roles could be perceived as more work or additional pressures, I find this is far outweighed by the benefits of taking on these roles. To be honest, taking on these roles has really helped me. They've extended my network, increase my connections, provide opportunities to raise the profile of audiology or audiology in Wales, and have certainly helped in the development of my own leadership skills and my abilities as a consultant clinical scientist. So I hope those examples have given you some insight into my role as a consultant clinical scientist in audiology and some of the things I do and I'm involved in. As I mentioned at the start, mine is not a blueprint for consultant clinical scientists in audiology, and whilst other examples would be different, I'd expect they would feature similar examples covering the GSP domains. And thanks for listening. Thanks, Sarah.
That's brilliant. Thank you, Jane. And I think that's really set the scene brilliantly in terms of the sort of the breadth of the roles of consultant clinical scientists, the different kind of domains, the different aspects that we excel in, that, you know, the purpose behind the role, you know, that there is that kind of that clinical and what can be done differently and what can be progressed further, possibly taking on aspects that medical colleagues might otherwise do, or really advancing the professional field, but also research, innovation, really pushing forward with those areas, leadership clearly, and so many other areas as well. So I think that's set the scene really beautifully. So if you've got any questions that have come to mind during the time that Jane's talking, do post them into the chat at the side, and then we'll pick them up after Martin and Teresa have spoken, and have a good kind of question and answer session time then. So Martin, I'm going to pass on to yourself next. Martin is consultant cardiac physiologist in NHS England, and we're delighted to have Martin come and talk with us today. We don't currently have anybody in a consultant role in cardiac physiology in Wales, or in respiratory physiology even, but quite a number of services really keen to start developing these roles. So we're really keen to hear your perspective, Martin. Thank you.
So I can probably come at this from 3 different angles, really. So I can come from my everyday clinical job angle, so what I'm doing every day sort of within the NHS. There are also other things that I'm not involved in anymore, but I have been involved with quite heavily in the past. So one of them is HSST, and that was basically setting up and delivering the HSST routes for cardiac, vascular, respiratory and sleep in England, in the UK. And now obviously that's spread across to Wales and Scotland as well. So I can talk to you a little bit about developing that programme and what I was always advising the students as they were going through, what they need to be sort of thinking about with their roles and how they should develop their roles going forward. And there was certain pitfalls that people were falling into all the time. So I can give you some practical advice around sort of developing the roles from that perspective. And then also from a national perspective, so currently I'm the Vice President of the British Society of Echo. So from a national sort of charitable perspective, I can see sort of where the horizon is in the UK and where things are changing and what sort of problems we're seeing and how you could maybe develop roles that would help address some of the issues. And hopefully by doing that, you'll probably be more successful in getting funding for these type of roles going forward. So generally from day to day in my clinical practice, so I very much started out from the perspective of, right, so let's develop a service that benefits the patients. That's the key thing. Anything that you can show and demonstrate is going to benefit patients and patient care, save money, save time, it is going to be a big goer, and people jump on that straight away. So we had a major problem in Manchester with accident and emergency, and it's a big problem everywhere across the UK. Basically, we had this issue where patients were coming in with certain cardiac presentations, so whether it be chest pain, whether it be shortness of breath, whether it be palpitations, whether it be syncope, so the really common sort of presentations that we see in cardiology. And coming into A&E or being referred to A&E via the GP, and then being in a situation where they were taking up beds on our acute medical units waiting for cardiology opinion. And that was putting massive, massive pressure on the cardiology team. So the cardiology registrars, the consultants on call, the FY1s, FY2s, constantly being asked to go and review patients in the acute medicine sort of setting. And a lot of the time, it was just a fairly trivial advice, or it was a lot of the time patients were probably medically fit for discharge and didn't need to be kept in, but they couldn't be discharged until they've had this opinion from a specialist sort of person. And we noticed this problem mainly due to the fact that our echo waiting lists were going through the roof. And we sort of looked into it. We did a lot of audit, looking at the backlog and where things were coming from. And then we decided that we would develop a particular consultant role to sort of address this problem. So the main thing was finding out where the problems are and how you can be the most effective person, so that if you want to develop a role like this, people can't say no. It's obvious. If you can present the data to them and present it in the right way that shows it's better for the patient, it potentially costs less because you don't have to employ another consultant medic, which obviously costs more than a scientist, and it quickens the process up. So we developed what we call a cardiac outreach role. And basically that was initially me on my own, practicing as a consultant scientist, effectively seeing those patients. So having a direct referral into my clinic, so my own specialist clinic that has its own clinic code, is set up like a consultant medics clinic, seeing these patients and getting them early access to diagnostics if they needed it. We quickly realised obviously we couldn't take everyone, so we had to focus it. So we focused on chest pain first. Chest pain was the main issue. So non-acute chest pain, so not patients who are having heart attacks, stable chest pain, getting them early access to clinical assessment, clinical advice, treatment if they needed it, and then diagnostics if they needed it, and early discharge. So what eventually happened was it eventually turned into almost like a virtual ward. So A&E was seeing these patients and then sending them home, knowing that within a certain amount of time, usually within 48 hours, I will be in contact and we do a telephone call. And then if they needed to be seen for a proper clinical assessment, I would bring them into my clinic, get them early access to diagnostics, often on the day. And then by doing that, we could give them a result on the day and also a treatment plan on the day. So it's very much a process where we're getting these patients in very, very quickly and getting them early access to diagnostics, advice, treatment, and then they could be discharged or set on the way to different specialists and whatever it may need. We very quickly realized that one person can't do that. So we developed a team of people. So now I lead a team that has a consultant nurse, and the consultant nurse was really important because we still have this prescribing problem that we're not allowed to prescribe in cardiac. So when I turn around and say to a patient, yeah, you've got angina, you need a beta blocker, you need aspirin, you need an ACE, I can't actually prescribe that. So having somebody who could oversee that process and could do that helps a lot. And we also have, to be honest, this is really important. If you're going to develop roles that are consultant scientist roles, you need really good support from the medics, and have somebody who is going to oversee and govern from a medical point of view to make sure that the things that you can't do or the things you have problems getting access to, you can overcome those hurdles. And that's really, really important. And I was very lucky. I've worked with the imaging consultants for many, many years. So we built up that relationship over time. So that's a really sort of big hurdle that you need to get across. So as well as the consultant nurse, we also have some advanced nurse practitioners and also Band 7 cardiac scientists who've come through the STP program, who are also working around in this clinic, and they're seeing patients with syncope, they're seeing patients with palpitations, They're seeing patients who are potentially short of breath and it might be heart failure. So we've got this outreach service that's expanded now to pretty much all the presentations, and we've got a team of like 8 people now working in this sort of advanced sort of practice clinic. I've seen lots of other roles develop, particularly through HSST. So I can tell you what the students who've come onto HSST and gone through the different sort of pathways and what they've been sort of looking at. And generally, it's very much the same thing. It's always a registrar level role that involves the assessment of patients. It involves very advanced practice. It involves making clear clinical decisions that effectively affect the patient's treatment and the diagnosis. And it's almost taking that medical role out, as though it's not like you don't need it, because you still need some oversight, but it's taking the responsibility, to me, of a registrar in the clinical assessment of patients and dealing with patients and running your own clinics and getting the patient to where the patient needs to be at a specific time. Cardiology is quite different from other things because it's split. So you very much have imaging people who do echocardiography, you do CT, you do cardiac MR, and then you have another group of people who do the cardiac rhythm management aspect. So the pacemakers, the electrophysiological studies, and the more sort of invasive stuff that we do within the cath lab. Because there's a distinct split between the two, the roles are slightly different that you see these sort of consultant scientists doing in the different disciplines. So I'm very much an imaging person. So all my sort of clinics and the stuff that I do revolves pretty much around that imaging aspect of cardiology. So for instance, when I'm seeing patients with chest pain, I'll very much use lots of stress echo, lots of cardiac CT, lots of cardiac MR. Those who are involved in the more sort of cardiac rhythm management and the electrophysiological type stuff tend to do pathways that are related to palpitations, syncope, and those sort of areas, and developing their own sort of clinics around those specific aspects. I mean, I've seen, this might be a bit controversial actually, but I've seen lots of roles develop based on the fact that some of the stuff we do, you might have to, for instance, put a cannula in and give contrast. And there's local sort of procedures in place for people to do that. And they see that as working as a consultant role because they're giving contrast to do a test. To me, that's not what a consultant role is at all. There's much more to it than that. It's not just about being able to put a cannula in and doing something special that maybe other people can't do in other trusts. It's developing that service, developing that sort of clear role. And it's almost like if you're not there, your clinic can't run because it's your clinic. Just like a medical consultant, if they're not in on a day or they're on holiday, their clinics don't run. So it's very much developing that sort of standalone, this is what we do. And if I'm not there, it doesn't happen sort of thing. Not just doing something very special on one particular test. It doesn't sort of give that sort of difference to me. Sort of nationally, things are changing. We've got a massive waiting list, like everybody has, but we've got a massive waiting list for echocardiography at the moment. And it just seems as though NHS England have cottoned on to this a little bit now, and it's becoming a major issue. And they're at us to try and develop ways to get rid of this massive backlog. And it's mainly because of COVID, but also because we don't have enough staff to deliver it. So I'm also working on potentially another type of consultant-led service now, and I'm working with the BSE on this as well, to try and get some sort of advanced sort of clinical triage of patients on these waiting lists. Because some of these people have been waiting. I mean, at Wythenshawe, our echo waiting list is 22 weeks at the moment, which is, it's ridiculous. It's terrible. So we're trying to think of new roles, consultant level roles, really expert roles where we can sort of impact these waiting lists. And one of the things we've thought about is this advanced sort of triage. So looking at those patients that have been waiting that potentially have more significant disease, getting them in quickly, clinically assessing them, doing the diagnostics and giving them a pathway to go to try and get the waiting list down as extra sort of clinics. So there's things coming up all the time, and like things you can think about that can sort of develop these roles all the time. It's just knowing what you need is that support. You need the support of your trust to be able to develop it. And if you don't have a clear idea with a clear reason for doing it, then you're gonna cross hurdles. But there's lots of different things, ways you can do it, and it's almost having the sort of knowledge of where you can make the most sort of impact. And one last thing, this is mainly just through my HSST sort of the teaching side of it. You have to, if you're going to go on and take someone through HSST and develop them as a consultant scientist, then they need to have a clearly defined job at the end of it that they're going to go into, so that they can tailor what they do through HSST and almost mold and shape that particular job at the end, rather than just going on to HSST and then coming out at the end and not having a role. And that's a big thing that I've seen from a number of different students who've come out of HSST, done really, really well, come up with really good, clear sort of pathways in imaging and cardiac rhythm management, and then have got to the end and have been still working as a band 7 for 2 years after that, and then have ended up leaving the NHS and going working in private practice at a consultant level. So if you're going to develop these roles, you have to be very clear at the start that when you finish your training, there's a clear role for you to go into, and use your training to mold and shape that role, because that's how you'll get the best out of the academic side of stuff as well.
That's brilliant, Martin. Thank you. That's really, really helpful. And you've given us some really good, solid examples there of those those clinical questions and how you can then translate them, and looking at colleagues as well and their roles, and then some of that process as well to help hopefully colleagues on the call to get a really good sense of what they can be doing to progress these. So we'll bring Teresa in at this point. Teresa Robinson is a consultant vascular scientist in NHS England, to give a sense from another of our clinical physiology areas, again, patient-facing disciplines, what these consultant roles can look like in our areas. And then hopefully we'll be able to come back to some of the points that you've all made, and ask you some questions. That'd be brilliant. Thank you, Teresa. Over to you.
Thank you. And thank you very much for the invitation to come and speak to you all today. I've been practicing consultant vascular scientist in Bristol for nearly 20 years. And I'm actually very proud that I was the very first clinical scientist in the UK to be accepted onto the highest specialist scientific register during the pilot phase back in 2014, I think it was. Now, I'm actually not quite sure of the audience I've got today, so I thought I'd better start with a couple of sentences about vascular science and what it is. So vascular science, we're assessing the state of the body's vascular plumbing, the major arteries and veins that are transporting blood throughout the body to all the vital organs. And it does that by the scientific and clinical interpretation of the complex ultrasound images that we obtain from the structure of the vessels and the hemodynamics of the blood flow within. And the clinical interpretation of that data, along with the patient's history and clinical examination, contributes then to the management of that patient's pathway. I have to thank actually Jane and Martin for their talks, because I'd really just say ditto to everything they said. It was really, really useful, both their eloquent talks, all applicable to life and vascular science as well. And then as an example of something then that happens in vascular science, we might interpret data from the blood vessels supplying the brain, the carotid arteries here, in a patient who's suffered a mini stroke, determine in consultation with the stroke team and the vascular surgical team whether or not that patient may benefit from a surgical operation to clean out those arteries. Now, as the head of service in my trust, I was obviously responsible for the integrity of all the clinical scientific knowledge base within the service and within the team, but also, as has been touched on by the other two, real key is contributing directly to the development and delivery of patient management pathways. And I heard development, that word, used quite a lot, and I would say that was a really key important word. So over the years, I've led the strategic redesign of numerous patient pathways. And some of those have now been redesigned several times as national and regional priorities have shifted and changed. So as an example of that, our DVT pathway, the deep venous thrombosis pathway, blood clots in the legs or arms, 10 years ago, the first redesign of that involved my team, my department, vascular science, actually taking over the scanning aspect of that service from our radiology medical colleagues. And working in partnership then with the medical nursing teams to ensure that the patient's got a speedy one-stop service. More recently, a few years ago, we were reworking that pathway, and I was working with the trust senior leadership team, the exec team, and with the clinical commissioners to basically evolve that service model and develop new business case, a more cost-effective model, really. And that actually required some quite tough leadership management decisions, because some of those decisions were on the surface of it detrimental to my actual own service and my team, because what we ended up doing was moving elements of the service out of the acute provider, where I'm based, to the community provider. So this was all for the benefit of patients, but had some impact on your team and service in your acute trust. And being able to sort of manage and make those decisions, it's quite a difficult choice to be had. But it's about sort of looking at that patient journey and what's important for the patient's pathway. So there's been numerous projects like that. I could give you a range of examples, and we've had lots of similar projects and working with quite a wide range of clinical partners. So, you know, we work closely with rheumatology, with oncology, with stroke, the Children's Sickle Cell Service, with cardiac surgical colleagues, and obviously with vascular surgery colleagues. The centralisation of major arterial vascular surgery a few years ago, that was a real fantastic opportunity to work with partners across 4 acute trusts to really revamp and standardise pathways for our patients and standardise all the protocols across all of the sites, introduce some new models of care. And for example, the vascular science services at the trusts took over the responsibility of managing all of the patients on surveillance schedules from the surgeons. So taking that on, looking after their schedules, looking after their repeat testing, and making clinical decisions after each patient visit as to what needed to happen next to that patient, whether they needed to have additional scans, additional tests, or be referred back to a different clinical group. So and again, it's about developing that as a service model and reviewing evidence and implementing all the best practice. As with the other 2, lots of supervision of people doing master's projects and PhDs and doctoral projects, NIHR grants, a really important aspect. And I quite liked what Jane said about, you know, sort of developing that culture of research and innovation and quality improvement. Really important to develop that culture for those things, because then people go on and really sort of develop their own interests in research then, and knowing that they've got the environment that will encourage and support them. So I think that's a real key element for the leadership skills of anybody really, but of consultant clinical scientist in particular. One of the things I've really taken pride of over the last decade or so is how I've built and skill mixed my team. You know, we've gone from a very small service. When I first took over, there was probably 2 or 3 of us in the service. We're now up to about 15, and so still quite a small service. But I suddenly realised the other day that for the very first time, I've got someone at pretty much every single banding. I have a band 2, a band 3, band 4, band 5, band 6, band 7, band 8A, band 8B and 8C. We've just got to work on the 8D and 9 clearly, but I'm really pleased that we've managed to skill mix and really pick everyone's roles, continually evolve what they are, and bring in new roles, using as well everything that's happened with modernising scientific careers, all the sort of work that's now going on with apprenticeships and everything. You know, it's a real opportunity to do things differently, and different people do different things, don't they? We've talked about consultant scientists taking things from medical colleagues so that they can evolve and use their training in different ways. But equally the same, you know, what now might have been something only a band 7 scientist did, actually that may be something now band 6 can do, and so on. And it just puts opportunities and growth patterns for everybody. So I really I think that's really important, that you don't just have a service that's just doing the same as it's always done, but it's looking at the service it's delivering and the workforce that is delivering it alongside of that. So a very large part of my role has been teaching and training, both directly in my own team, but also taking on national roles, things you've already heard about as well. Working with my professional body, we revamped clinical accreditation scheme for vascular scientists. Did a lot of work with the National School for Healthcare Science back when modernising scientific careers was starting. I was the lead writer for the STP curriculum for vascular and for the HSST curriculum as well. Chaired the regional workforce group for all the physiological sciences in the southwest of England as that was launched, and lots of direct teaching for STP, HSST, other master's courses. Also have had opportunities as an ultrasound physics expert to teach internationally in some of the European universities as well, and president of professional bodies, all those sorts of things. And I've been able to use all of that to support other scientists in my own trust as a trust lead scientist and really help and support them. I've actually just moved on in the last week, so I've moved on from my trust now to work for NHS England in the southwest of England as the head of physiological sciences. That's probably what comes next after consultant clinical scientist, so we'll leave that for another day. Thank you, I hope that's okay.
That's fantastic. Thank you, Teresa. That's really, really good. And I'm just getting a really strong sense from all of you speaking around this kind of strategic leadership and the strategic responsibility that comes with these roles. So very much not being about, you know, a local service lead doing the same as before, but actually about taking that forwards. You know, what does the local team look like differently, and developing that? What does the service around that look like differently, but also reaching out internationally as well, and really kind of driving the professions. And I think that's part of what's exciting about these roles, isn't it? It's the you know, the excitement of driving our profession as a whole across healthcare science and all of our areas forwards together, and having that, you know, these skilled individuals such as yourselves in being able to do that. So I think in terms of questions, we've had a couple come through on the chat, which I'll pose, and a couple for myself. But equally, if you know, if there's anybody in the room that would like to pose a question, do either pop it in the chat or raise a hand if you prefer. So Lennore's posed a question around how do you see the role of a consultant clinical scientist developing over the next 5 to 10 years? You've talked quite elegantly about sort of seeing those wicked challenges and taking those on and developing those. And then I suppose it's always looking to the next, isn't it? So in your areas, what does that look like to you? What do you see as kind of 5, 10 years, those roles possibly? What else could those roles take on? What could they look like other than, you know, driving forwards in the same way that you've already described?
I think I would like to see, I would really like to see more consultant clinical scientists and just clinical scientists in general just working in their divisional directorate, executive, senior leadership trust level, because I think the scientists have so much to offer in terms of strategic thinking and leadership and clinical expertise, and yet that's often not being picked up at a senior leadership level in trusts. If you look at the board makeup and all of those things, it's very unusual to find a scientist at that level. I'm not saying there aren't some, because I'm sure there are some. I don't know how many chief executives in the countries are come from a scientific background, but I'd really like to see that as a change, and I see no reason why it shouldn't. I think the scientists are slowly coming out of the shadows and from the little cupboards along the corridor, which is where we tend to find the scientists. So in my mind, that's really where I see it develop. So those sorts of real cross-cutting skills that scientists have, and you know, they understand so many different pathways because they touch so many different clinical patient pathways and are somewhat unique in that respect. And they should be really involved in the networks that are available for different pathways, you know, cancer networks and cardiovascular networks, etc., etc. So they really need to be sort of in there, come out of the cupboard, basically, get on those things.
That's a brilliant way of putting it, Teresa. Thank you. Martin.
Yeah, I was just going to say something similar to Teresa, actually, because I think it would be really good over the next 5 to 10 years just for them to be more of us and more of us about who are showcasing what we actually do and what the role can actually, where it can take you and how you can do it. It sounds really bad, doesn't it? But if anyone ever thinks about healthcare services, all they tend to think about is doctors and nurses. And that's just how it always has been in the past. And I think unless we start to get ourselves up to these sort of board levels and in these discussions at this sort of higher sort of executive levels in trust, it's still going to be people don't exactly know who we are or what we do or what the role is. And we've got to get to that situation where when people think about the NHS, they think, oh, there are scientists that do this and they do that. And then we'll encourage more people to take up these roles. We'll encourage more people into the profession, because I suspect vascular and audiology are exactly the same as cardiac in the fact that we don't have enough staff. We've got a massive waiting list. It's difficult to get people into the profession. We need to showcase what we're doing and where you can go in your profession. And then hopefully in 10 years' time, there'll be 3 times as many consultant scientists and 10 times as many people coming into the profession at the bottom wanting to be a consultant scientist in 20 years' time.
Absolutely, completely agree. Lynn.
Sitting here, it's just wonderful. I love this because one of the things that's so fantastic about healthcare science is that we can adapt, we can progress. you know, we can address workforce needs. We'll do, it's not that we'll do anything, but what we do it really, really well. And I think it's just now is that people are listening now and seeing the results of using healthcare scientists more wisely. And it's just fantastic listening to sort of different physiological sciences where this wouldn't have happened 10 years ago. Yes, you may have had the roles, but people perhaps wouldn't have listened as much. And I just think it's a really exciting time to be healthcare scientist. So anyway, it's wonderful.
No, I completely agree, Lynn. And I just, you know, I'm thinking, how can we amplify this? How can we collect together these messages and, you know, and make it just really clear across with the profession, but also wider, you know, that these skills are here. You know, this is here for the taking for NHS Wales. I completely agree. John.
Yes, thanks, Sarah. So, so my name's John Day. I'm a consultant in North Wales. I work with Jane actually in audiology, and I'm also an assessor for the school for the higher equivalency. And I'd just like to say, first of all, thank you so much to the three of you, because I think you've really conveyed the opportunities. That's what I see it. I think in the physiological sciences in particular have got great opportunity, maybe compared to our counterparts in other branches of healthcare science, because we're so patient facing, and there's a lot of opportunities really to extend our roles, particularly at the top end, as compared to what medics are offering as well. I'm just thinking here, some of the people in the audience might be thinking, you know, they don't have the luxury as they do in medicine, where there's maybe a 2 or 3 or 4 medical consultant posts existence at each health board or trust, and when they become vacant, then they go and apply to get it, and they've got on a register and all that, because they'll be thinking, well, hold it, there aren't any consultant posts in healthcare science in my discipline at my health board. And I'm just thinking from their perspective, I'm thinking, what do they need to do to see those posts created? Because where we have consultants there, they can do their bit to fight the corner and maybe create some more posts. But if they don't exist in the first place, what do those individuals do? And that's why I'm just thinking now as an assessor, when I look at equivalency applications, what I'm looking for is leadership, but particularly initiative, and people taking the opportunity that presents to go and push forward. And what I mean by that is contributing not just in your own discipline nationally, which I think is really terribly important, but also raising your profile locally. So getting involved, like Jane mentioned as well, getting involved with our Health Professions Forum, which is a great opportunity in Wales. Getting involved in clinical effectiveness committees, for example, and I've chaired that at one of our hospitals in North Wales. It's just actually stepping up and being proactive, rather than expecting things to fall in on a plate for you as an individual. And I think if you've got the acumen, the ability, then you go and create the role, so to speak, because you'll demonstrate that you're valued, and ideally not just valued, but you become invaluable, because the organisation can't do without you. Not just because you're just your clinical role, which has been illustrated by my colleagues, but also what you can contribute beyond that within high-level leadership, clinical leadership at your health boards. I'll get off my soapbox now, but thank you so much, because I think what you're saying I think it's really, really important to say. What we want to do is motivate people, and so they know what they need to go and do. It's not something that's done overnight, I should add. My experience, it takes some years to go and get there, but you know, but go for it. That's what I'd encourage people to do. Thank you.
Thank you, John. And a great question posed. So for colleagues on the call who are in services that don't currently have consultant roles, Martin, what's your advice for them?
So John makes a really good point, actually, because I was just thinking, when was the last time that I actually see a consultant cardiac scientist post advertised on NHS jobs? I don't think I've ever seen one, ever. The majority of students that are coming onto the HSLT programs and the majority of people that are developing into these roles are very driven people who've thought about things, obviously made it clear to the leadership team within the department that that's where they want to go, but they've thought about the role, how they can change the role, how they can expand the role, and how they can move themselves from just being a scientist to a consultant level scientist, and how they can affect the service. And that seems to be where all the new people are coming from that sort of aspect. You very rarely see a job description already written for a specific role within a department, asking people to come in and apply like you would do for a consultant medic job. It's very different, and we have to. I mean, one good thing we could do going forward is collate all these examples of the different job roles. So, for instance, what I do, what Jane does, what Teresa does, what other consultants do, and then use that to sort of advertise what these roles are and why people do them. And this is a really good job description of a role of a consultant scientist, because we have them, aren't they? But they're very generic sort of things, and they're not specific to a particular discipline or an angle within a discipline. That would be something useful going forward, I think.
No, I completely agree, and you know, we'll be more than happy to do that as a programme. I think that'd be a really good piece of work for us to take forwards. Teresa, what's your thoughts?
Yeah, no, exactly as John has alluded and Martin has just sort of wrapped up. I think you're right. I suspect, I don't want to speak for Martin and Jane, but I suspect your roles, consultant roles, weren't advertised. You went out there and you just kept on pushing and doing things and shouting loudly, etc., and use that initiative. And that's actually quite a difficult route to take, and but does yield results. But I think in terms of advice for others, you know, come together with a band of fellow people and run down the corridor hand in hand shouting and stuff. So come together as a group and you'll be a louder voice. You know, if you have a trust lead scientist and stuff, work together with fellow colleagues who also kind of want to do these things, but perhaps just need some support as well. So that's certainly something I would have a look at.
No, that's thank you, Teresa. That's fantastic. So just the final few minutes then of the session today. So any sort of final thoughts from yourselves, Jane?
Yeah, I'm just going to say, I think points other people have made, I think it's about working together. I think if we collaborate and work together on this across the UK, Wales, working with England, you know, we've got colleagues here, and you know, and across disciplines, I think we can probably be more effective. So I think taking that opportunity after today to kind of reach out and work together, as people have mentioned, I think that'll be really helpful.
Thanks, Jane. Martin, any final thoughts from yourself?
Yeah, I think one of just the main points to consider is don't be frightened in developing roles to this sort of level, because they have massive impact. They have really massive impact, and the impact on the patient can be astounding, the amount of impact you can have on a patient by developing these roles. And you'll be surprised by developing them just how that pulls everybody else in the team to developing these sort of things, and you get the sort of message across. And I'd love to be in a situation where someone put a question on, I think, about how many consultant scientists do you have in a particular, do you need in a particular service? Obviously that depends on lots of different things, but for instance at Wythenshawe where I work, there's 3 of us, but we're a big tertiary department. We've got lots of things going on, but it'd be to have 1 in every department. That would be brilliant. That's got to be where we've got to be heading for. And then once you've got 1, you can get 2, then you can get 3, then you can just keep growing. Absolutely.
I think that's the real challenge, isn't it? That's the real kind of direction of travel for all of us, is these being a standard part of our roles, and surely that's the strengthened career pathway that we talk about. Surely that's the, you know, that's the ideal in terms of modernising scientific careers, to have these roles at the top in all of our areas. Teresa, final thoughts?
Yeah, I think what's interesting now, I've sort of moved into a regional job for all of physiological sciences, covering various different topics, but I really see the benefit of everyone working together and pulling together, supporting each other, promoting each other, developing, representing each other. There's definite strength that will come from that. So that would be my final thought.
No, I completely agree. So it just leaves me to thank speakers today. Thank Jane Wild, Martin and Teresa Robinson for your support and your reflections and your individual experiences. I think that's been really helpful in illuminating some of the specifics around the roles, as you've mentioned, very much keen that we take forward this work further now, and we gather the experiences of yourselves, the roles specifically, and colleagues across the UK that are undertaking these roles across clinical physiologies. Thank you all.